Two, one. Sir, we are live now. Now we can start the meeting.
Good evening. Welcome to the Bombay Spine Society Resident and Fellows Spine Training Program. I'm Dr. Gautam Zaveri, the President of the Bombay Spine Society. This program is the brainchild of Dr. Amit Sharma, the Dr. Kshitij Chaudhary, and Dr. Satyen Mehta, who will be conducting or convening these programs for the future. We would like to thank our partners in these ventures, the OrthoTV and Intas Aquila, manufacturers of Gabapin NT, who will be supporting us for these programs. The Bombay Spine Society will be running this program. Today's program is on lumbar disc herniation. And with me, I've got some top faculty from Bombay, Dr. Devesh Dholakia, Dr. Satyen Mehta, Dr. Agnivesh Tikoo, and Dr. Saijyot Raut. The program will be divided into two halves. In the first 1 hour, we will have lectures. And in the second 1 hour, we will have interactive case-based discussions. The program is primarily focused at spine fellows and at senior residents in training. And the goal is to cover a lot of basic information on these subjects. This program will be held on a monthly basis on the second Thursday of every month between 8:30 p.m. and 10:30 p.m. The next program is on 7th of March, where we will be discussing evaluation of the spine, history, examination, and investigations. The subsequent program is on the 11th of April, again a Thursday. The topic will be lumbar canal stenosis. Just to give you a little brief, the Bombay Spine Society is probably one of the oldest spine societies in India. In fact, the Association of Spinal Surgeons of India was started by the Bombay spine doctors, and it has grown subsequently over the years. The BSS, however, was formally launched only in around 2016, and since then it has grown from strength to strength. Today, the Bombay Spine Society has about close to 100 members who are doing purely spine surgery. Every 3 monthly, we have a clinical meeting. The first of these clinical meetings for this year is going to be held on Friday, the 21st of February. The venue will be Status Restaurant opposite PD Hinduja Hospital in Mahim. There is going to be a lecture on rheumatological afflictions of the spine by Dr. C. Balakrishna, a well-known rheumatologist. And this will be followed by interesting case presentation by our members. All spine fellows and residents from Bombay who are interested are welcome to attend this meeting. These meetings are sponsored by Sun Pharma for us. In June, we will be having our annual meeting, which is the Bombay Spine Society Conference 2024 between 21st June and 23rd June. This is going to be held at the lush green Oleander Farms in Karjat. It's primarily a residential meeting. And the theme of the program is going to be sagittal spine pathologies or problems. On the morning of Friday, that is 21st June, we will have a hands-on cadaver workshop. 2 workshops are going to be held. One will be on posterior cervical spine surgery, and the second one will be on spinal osteotomies for deformity correction. Details of the workshops and of the conference, etc., will be launched on the Bombay Spine Society website within a week or 10 days. So please keep abreast with it on that website. BSS Con 2025 is going to be in Bombay in July 25. The venue will be is still undecided. Again, information on this will be available on our website. it's going to be a huge meeting, a joint meeting with the Minimally Invasive Spine Surgery Association of India and the International Minimally Invasive Spine Surgery Society. And I'm sure it is going to be a fabulous meeting, which all of you will gain from a lot. Again, just to thank our sponsors, Aquila Intas, who are manufacturers of Gabapen NT, Gabapen ME, Gabapentin, and Gabapen SR. Now, without much ado, let me start the program. The first is a lecture by Dr. Saijyot Raut. He will be speaking about the anatomy, the function, and biomechanics of the lumbar intervertebral disc. Sai, it's all yours.
Thank you so much, sir. Thank you for the introduction. So today I am going to talk about the intervertebral discs, its anatomy, function, and biomechanics. So we all know what the intervertebral disc looks like and what it is. So it's a pad of a fibrocartilaginous which lies between the two vertebrae. So it allows the vertebrae to bend, twist, all this stuff. The compressive loading which is there between the two vertebral bony vertebrae, it takes the compressive loading. That is the job of the disc. So why is it important? The structured disc, it is very important because it can be physically disrupted, which can lead to degenerative changes and leading to other pathologies and chronic back pain. So let us see about it. So what is the composition and functional anatomy? So there are three major compositions and three major part of this disc. First is the diagram which you can see in the A, which is a grayish part, which is written as NP. It's a soft deformable, which is called as nucleus pulposus. Second, in the diagram B, we can see a concentric layers of fibrous tissue, which is called as annulus fibrosus. And third is the cartilaginous end plates or the CEPs, which we'll see later. So let's see one by one what it is. First is the nucleus pulposus. Very important, the composition of the nucleus pulposus. I have mentioned what are the major components of the nucleus pulposus. First is proteoglycans. Second is made up of type 2 collagen. Third is elastin fibers, and majorly it is made up of water. So now we have a diagram of nucleus pulposus. It's a gelatinous structure. It has most of the its volume is covered. 40 to 50% of the volume of the adult disc is covered by this nucleus pulposus. It has high water content. It exhibits a hydrostatic pressure. So what it does is whenever there is loading on this structure, it expands and it gives a compressive loading. It generates tension and it allows the annulus fibrosus to expand its fibers. So as we saw, its main constituents are proteoglycans, collagen, and water. So proteoglycans, they account for 35 to 65% of the part. So what are these proteoglycans? Proteoglycans, they can absorb water or they can bind water. That is how there is water retention in this nucleus pulposus. So there are 5 to 20% of fine collagen type 2 fibers also, and they provide loose three-dimensional fiber networks and holds the nucleus pulposus together. The remainder part of this nucleus pulposus is non-collagenous protein and some part of protein. Next is our annulus fibrosus is the major part because it is a slightly complex structure than the nucleus pulposus. Annulus fibrosus is nothing but it just, can you see the diagram? It is made up of concentric rings, which is 15 to 25 concentric layers, which are called as lamellae. So their thickness is about 0.5 to 0.05 mm thickness. It can vary in its position and the levels. So approximately half of them are circumferentially incomplete. The percentage of incomplete layers, they increase with the age. That is how the problem starts. So they have strong collagen type 1 fibers which are oriented. So these the layers of the fibers, they are arranged in an angle. So they are between 25 to 45 degrees in relation to the transverse plane. The angle of inclination increases towards the center of the disc. As you go inside the disc, the inclination of the ankle increases. it is binded together by a bridge called a translaminar or collagen based bridge. So the collagen fibers in this enables to develop tensile hook or a circumferential stress, due to which there is a pressure in the nucleus. So in a healthy intervertebral disc, annulus fibrosis also contains mostly 60 to 70% of water. Dry weight, if you see, approximately 20% is proteoglycans, 50 to 70% is collagen, and 2% is elastin. As we move from outside to inside of the annulus fibrosis, we see that proteoglycans, actually water, and collagen type 2, they increases, whereas collagen type 1 decreases, which is seen from the outer to the inside. Mechanically, if you see, type 1 collagen provides strength to all the structure. Type 1 is the collagen fiber which provides strength. Type 2 collagen forms the meshwork of the structure, and it binds with the proteoglycans. Hence the water is enable and withstand this large compressive forces within this structure. Now the third part, which is another important component, is the cartilaginous end plates or the bony end plates. So cartilaginous end plate or the bony end plates are the bilayer which separates the vertebral body from the disc. So primarily, first it serves as a growth plate for the vertebral body, which is thick during the primitive infancy, and it occupies the substantial fraction of the intervertebral disc. So with growth, as you grow older, this cartilaginous disc also becomes thinner and thinner, and it becomes so thin that it becomes in millimeters. So what are it composed of? It is composed of rounded cells, which is in the extracellular matrix of proteoglycans, collagen, and water. So again, the thickness of this cartilaginous end plates may vary with position and levels of where it is. Usually at the periphery, the collagen fibers in the lamellae of the annulus fibrosis are continuous with the collagen fibers in the end plate. So some of the fibers are in the continuity of the annulus fibrosis, whereas centrally, where there is nucleus pulposus, they have a convoluted integration. Now, after we see all these three structures, we need to know what we need to differentiate between the two. So this is the differentiating diagram where we can see annulus fibrosis at the one part and nucleus pulposus at the one part. What are the major differentiating factors between the two? The collagen network, which is there, it is 60 to 70% in annulus fibrosis and 20% in nucleus pulposus. Mostly it is type 1 collagen in annulus fibrosis and type 2 in nucleus pulposus. Okay, and proteoglycans. So coming to proteoglycans and water content, 30% of annulus fibrosis is proteoglycans, and it can have 60 to 70% of water content. In nucleus pulposus, 60% of nucleus pulposus of dry weight is proteoglycans, and it can hold up to 90% of water. What type of cells they have? They have elongated cells in annulus fibrosis, which is fibroblastic phenotype, and here it is chondrocytic phenomenon type, which is coexisting. Now next we come to the blood supply. As you can see the structure or the diagram there, the disc derives its supply through the two major capillary plexus. You can see the segmental artery. Once plexus penetrates 1 or 2 mm into the outer annulus, supplying only the peripheries of the disc, and the other capillaries it supplies in the beginning of the vertebral body. So it penetrates the bone and it terminates into the bony and cartilage junction. It supplies there. So now it is only at the periphery, it is not at the center. So if you see the center nucleus pulposus is as far as about 8 mm away from the blood source. So it is avascular. So because of its avascular properties, whatever it is a limited vascularity, the intervertebral disc becomes the most important physiologically. It mainly it depends upon, for the nutrition part and everything, it depends upon the diffusion. The capillaries don't reach there, so the whatever nutrients it has to take, it is always by diffusion. Next, we go on to what are the innervations for the degenerate of the intervertebral disc. So we can see in a normal disc, only the outer 1 or 2 mm of the annulus fibrosus is innervated. The remainder of the annulus or the nucleus is avascular and is devoid of the neural condition. This is only in the normal disc. Sometimes in the degenerated disc, it's said that these nerve endings, they penetrate and they have the supply. So the end plates is of subchondral bone is innervated by basivertebral nerve, which is present, and it also the end plate innervation is also resembles of that of this annulus, like it is in the annulus, and it is increased again whenever there is a degeneration or increased bony damage, the nerves endings increases. So coming to the functions of the intervertebral disc, what are the major important functions of intervertebral disc? So as we all know that the shock absorption is the major functions of disc. It provides cushioning and it helps us with the daily impacts, like when we walk, jump, or do any other activities. It serves as a jelly-like substance. It provides a cushioning which acts as a shock absorber. Second is it gives support and stability. They provide a structural integrity to the spine. They contribute to overall strength and stability. The distribution of the pressure is equal because of this. So overall, they give us support and stability. Third is flexibility and movement. The disc allow flexible movement. So they give us very wide range of movements in the spine, which includes all these twisting, bending, extension, flexion. So when the spine moves, the flexibility is because of the nucleus pulposus. It shifts within the rigid annulus fibrosus. The outer covering is there, and it changes shape and size because of we have movement. Another important function of intervertebral disc is separation of vertebrae. The discs serve as they separate each other by in the spine, creating space so that between the two bones, when the disc is present, they give space for the nerve to exit from the foramen. So that that space is available because of the disc only. Last but not the least, it's nutrient transport. As we spoke earlier, there it is avascular in nature, and they rely for nutrition mostly on the diffusion. So the transport of nutrients, water, whatever the waste is through this avascular nature, and it's through diffusion. So nutrient transport is one of the main functions. So now let's come to the final part of this section, which is biomechanics of degeneration. What is the cause of degeneration, and why does it happen in the disc, and why is it so important part of the spine, and why is it easily degenerated? So because of first is it has a lot of water content. So first is because of loss of water in the disc. So this is a hallmark feature is degeneration. Progressive loss of water content will lead to dehydration, and then it also becomes weak, and it has dehydration reduces the ability of the disc to absorb the compressive forces, and the shock absorbing properties also go down. So that is one. Second is changes in tissue composition. So what happens is there is the collagen fibers, which are the major in annulus fibrosis. They become disorganized or they become fragmented, which leads to changes in tissue composition and leading to degeneration. Third is loss of disc height and stiffness. Majoritarily, whenever there is degeneration, the disc shrinks and there is a loss of discal height, which is compromising the spine stability. The biomechanics, the facets and everything gets hampered, and the biomechanism, the loading pattern in the spine, it all gets disturbed, which leads to unequal mechanical load sharing and gives rise to degeneration. Again, the fourth, coming to the altered load distribution. Again, like I mentioned, because of disc height degeneration, the load distribution over the spine, over the adjacent spinal structures such as facet, ligaments, vertebral bodies, and they vary, and there is increase in stress, there is increase in strain, potentially leading to degenerative and instability. Second last is changes in fluid dynamics and nutrient supply. As we mentioned, nutrient exchanges is compromised because of the degeneration, because the water is lost, and it biomechanically the integrity of the disc is hampered, reducing the flow of the nutrient supply, and it becomes dysfunction. Last but not the least is the increased susceptibility to the injury. This biomechanical changes associated with degeneration, such as reduced height and altered, they increase subject to the disc injuries, or let's say a mechanical failure. This can lead to disc herniations, annular tears, or any other conditions like facet atrophy and degenerative spinal condition. So this is how there is a degeneration of intervertebral disc, and that is why it is one of the most important structures of the spine. So with this, I would end my talk about the functions and biomechanics of intervertebral disc, and move on to our second speaker, who would tell us more about the lumbar disc problems. Thank you so much, sir.
Thank you, Sai. I think that was a wonderful talk on lumbar intervertebral disc anatomy. Just a couple of quick questions when Agnivesh is still setting up things. Is that when you say shock absorber, that means it takes compressive loads, isn't it?
Correct, sir.
The disc. Does the annulus also bear the compressive loads, or it's only the nucleus? What happens on compression?
So because of the compressive load, sir, the water content in the nucleus pulposus is more. That is why it has properties to expand. That is where it plays a very important. Nucleus pulposus also do, but nucleus pulposus is mostly for expansion. So whenever the watery structure, which is nucleus pulposus, gets all the compressive load, it tries to expand, and the nucleus fibrosus expand accordingly in the axial way.
But it cannot expand because the annulus is keeping it in place, isn't
Place,
it?
sir. Yes,
So
sir.
the water content then possibly diffuses into the vertebrae?
No, so it is contained only, sir.
Okay. And the nutrition to this place, you said it comes from those vessels, and then where from across the end plate, it comes across the end plate?
Yes, the end plate, it is due to the diffusion.
Okay. Because of the diffusion through the end plate. So the diffusion through the end plate is only one way or two way?
It is two ways, sir, because it also excretes whatever the waste it is from the disc outside.
Right. Any other questions from anybody over here to Sai about the biomechanics and the function and the anatomy of the intervertebral disc? I think he made it very clear that there is a central nucleus pulposus and there are peripheral annual filar fibers. The primary function of the nucleus pulposus is to help to prevent abnormal loading in compression, and the collagen fibers prevent abnormal tensile forces or distraction forces from acting on the spine. The annulus fibrosus also acts as a containment area for the nucleus pulposus, because nucleus pulposus is a jelly. It could just slip out if there was no annulus to hold it in place. So I think that is very clearly this thing, and I think beautifully is told us that as age goes by, degeneration occurs, the water content of the disc reduces. And as the water content of the disc reduces, the annulus, which was no longer taking the compressive loads, now starts taking compressive loads, which it was not capable of doing. And therefore, it develops microscopic tears in it. And that is what eventually results in a disc prolapse. So I think that's very good. Question for you from MJ. Sai, how to detect annular fissure and how important is it as an MRI finding?
Hello? Yes,
Yeah,
sir.
Sai, can you hear
I
us?
think this is about the MRI and everything. We'll take up later when we see the MRI findings and everything. We have high intensity, everything which we will be showing. There will be explaining how the tear in the annulus.
Okay. All right. Any other questions? Anybody?
Looks like.
All right. So if there are no questions for Sai, then we move on to the next talk, and that is Dr. Agnivesh Tikoo, who is a consultant spine surgeon at the Apollo Hospital in Navi Mumbai and at the Lilavati Hospital in Bombay. He is going to talk to you about the Diagnosis. How do you diagnose on history, examination, and investigations the lumbar intervertebral disc prolapse? And what are the differential diagnoses? What are the imposters that you should be aware of which can mimic lumbar PIVD and cause a problem? So, Agnivesh, over to you.
Thank you so much, sir, and thank you, BSS, for giving me this opportunity. So the diagnosis of lumbar prolapse disc is clinical, based on medical history and examination. It's based on radiological imaging, and it's based on the marriage between the two, which is clinico-radiological correlation, which eventually makes it much more relevant. Unfortunately, we as spine surgeons have a history that we want to get quickly to the examination, and which was also shown in a very interesting study where it was shown that almost 1/4 of the surgeons would or physicians would interrupt a patient while he's telling his history at a mean of 18 seconds. But when you don't take the medical history properly and you sort of get to examine the patient quickly, there will be somebody who's just standing next to you, your colleague, and if he picks up what you have missed, then you can land up in a trouble. So in medical history, a classical prolapsed intervertebral disc would start as a back pain with a gluteal radiation, which is initially back more than leg. Slowly, the leg pain would become more and more prominent, with almost back pain disappearing, staying as a gluteal pain, and predominantly in the radicular distribution of the nerve, which it is affecting. There can be numbness, tingling, paresthesias, and weakness in the distribution of the radical or the nerve which is getting affected, or the patient may directly present with deficit. And the worst one is the cauda equina syndrome, either impending or complete, presenting to ER. It may present after an event like lifting heavy weight in gym. Deadlifts, which many youngsters like to do, are one of the most prone exercises for leading to a slip disc. Elderly people, or sometimes even younger one, after a prolonged bad bumpy road travel, can also complain of such pain, which eventually may progress to a slip disc or a prolapsed intervertebral disc. It may be completely insidious in onset, which means that the pain is just started out of nowhere, and slowly it worsens despite whatever measure the patient takes. Or it can present as an acute or chronic, or worsening of a pre-existing radiculopathy, wherein the pain becomes much more severe than what it was before. Let's get to the examination part. So you may examine the patient in one of these three situations. One is an ambulatory patient reporting to your OPD. The other may be a bedridden patient who is in severe pain. And third one will be like a cauda equina syndrome who is presenting to emergency. So when a patient comes to your clinic or to OPD, you can see sometimes a sciatic list or a list which is sideways bending of the torso because of the prolapsed disc compressing on the nerve. Usually the pelvis is leveled in these cases, and so are shoulders, but the patient is just shifted towards one side. So if the disc is presenting towards the shoulder, then there is a tendency of the vertebral body to shift towards the opposite side, thereby taking the compression away from this affected root. If the disc is axillary, then it would tend to shift towards the same side, thereby taking the compression away from the affected root. Examine the gait of the patient. The patient may mimic a hip or a lower limb pathology. Having antalgic gait means when he puts weight on his foot, he gets a sharp pain, and that prevents him from keeping the weight on that foot for longer. In an L5 affected root, where there may be a Trendelenburg or a gait or a lurch gait where because of the abductor weakness. The patient may have a high stepping gait because of the foot drop that he has developed because of the radiculopathy. There may be an extensor lurch or difficulty in toe push-off in an S1 radiculopathy. And in upper lumbar discs, you may have knee buckling, which patient especially notices when he's coming down from stairs. Paraspinal spasm may be evident as a sort of a knot or a localized sort of a swelling within the muscle, or it may be just prominence of the central furrow, which patient is very tender to touch. Coming to the neurological examination, there are two types of neurological examinations we do. One is the focused and other is the detailed. The focused is the one we usually end up doing in our clinic scenario because we are limited by the time and circumstances. And focused means that you examine the patient with what complaints he is coming, like the patient is coming with a lower lumbar radiculopathy. So you do SLR, you do all the tests, you check the neurology, and then you do a negative examination to rule out the confounding things like pain originating from hip joint pathology or a SI joint pathology, along with ruling out myelopathy. A detailed examination would be, which you would do in an inpatient who is going, you're going to prepare for surgery, where you sort of check from everything from head to toe. Absent ankle jerk may be the only sign in an S1 radiculopathy, so do not forget to see the ankle jerks. Mild EHL weakness is noticed in many patients. We always should correlate it whether the patient is able to do a heel walk in these and whether the hip abductor power is preserved or not. Don't forget to see the knee jerk for upper lumbar discs. Examine the distal vessels because they are very important. Vascular claudication is very common as the patients who have more heart diseases, smokers and all. So never ever miss to examine the distal vessels. And then finally, we come to the special tests. So special tests are the root tension signs and the tests for hip and sacroiliac joint examination that we do to rule out confounding pathologies. So root tension signs basically rely on one thing, that there is a limit to which the sciatic nerve or the lumbar roots can extend or sort of elongate, which slide through the neuroforamen. And when this neuroforamen or the path of the root is impinged upon or pressed upon by a bulge, it increases the length of the path and thereby making it prone to elicit pain while the nerve is being stretched. So SLR or straight leg raising test can be active or passive. Active means the patient is himself lifting the leg. This is more specific for sacroiliac joint pathologies, whereas passive is more specific for ruling out lumbar radiculopathies. Bragard sign is a sign wherein when you lift the patient's leg, you do a SLR and then you elicit the pain. You lower the leg and then you sharply dorsiflex the ankle, and that would reproduce the pain. So there are a lot of root stretch signs which are there, and the list is unending, but we will concentrate more on the ones which we do commonly clinically. So straight leg raising test is one of the most common tests that we do in clinical scenario. So the examiner's one hand is holding the knee extended, the other at the ankle and lifting the leg, and you're looking at the patient's face to look for the pain. It is set positive if the pain in the radicular distribution is reproduced between 35 to 70 degrees. Why this? Because between this degrees is the one where the slack of the nerve root is taken, and beyond 70 degrees, it has been shown that it does not result in stretching of the root. It is quite sensitive, which is 72 to 97%, but it is low on specificity, which means that absence of SLR does not rule out the absence of a disc prolapse. And discs which are more than 6 mm would be are more likely to be SLR positive, and lifting the leg would cause pain in the ipsilateral leg. There's another test which is crossed SLR. It's highly specific, which means if a crossed SLR is positive, then the fact that you are not having a disc herniation is very, very less likely. So you are lifting one leg causes pain in the other leg. Femoral nerve stretch test is done for the upper lumbar roots or radiculopathy, wherein you make the patient prone, stabilize the pelvis and lift the leg, and the pain is reciprocated in anterior thigh in the distribution of the nerve. Malingering is something which you should be aware about, and there are Erd signs, Waddell sign, which help you to differentiate between a patient who is sort of having real pain and having malingering. And one of the common things is we do a seated SLR. If the patient is not having pain in seated SLR, but is not letting you do an SLR, then probably there is something wrong and this does not match up. So let's come to the second part, which is the radiological imaging. So we see X-rays, MRIs, and CT scans. Now, X-rays are very non-specific. We do not get much information, but sometimes calcified discs are seen, as in this case at L4-5 level, where we see a calcified disc. Myelography, in certain cases where MRI is not possible, is helpful. Now, MRI, there's a consensus article between many task forces of NAS and American Society, where they generalized or sort of made uniform the terminology which we use commonly in MRIs. So these are the MRI common findings which we see: fissures, high intensity zone, degeneration, and herniation. This was the question which was asked by one of the participants, that the fissures. So fissures or high intensity zones are of three types, and the radial fissure, which is extending from center towards the outer layer, is the one which is most significant. We'll concentrate more on herniation, and the types of herniation are bulging, protrusion, extrusion, and sequestration. Let's look at them one by one. So bulging means bulging like a fat belly or a fat tummy. So the whole disc is bulged out. It's usually more than 25 centimeter, 25% of the circumference of the disc. Usually the bulge is less than 3 mm, and there is loss of concavity, which is at the posterior margin of the disc. It's also termed as bulging, like in this case. Protrusion is when the base of the disc is wider than the extruded material. Usually these are the ones which are contained, wherein the layers of the annulus are preserved and the nucleus is bulging through it, like in this case, where you see like a hill which is poking into the spinal canal. Extrusion is when the base is thinner, which essentially means the annulus has ruptured and there is sort of extrusion of the disc material or nucleus towards the neural structures, like in this case, where there's a tiny rent and there's a gray extruded material within the canal. Sequestration means when this extruded material is broken from the parent disc and it is lying freely into the canal. The term migration is used to describe whether disc has moved up cranially or down caudally towards the respective vertebral bodies. They may be extruded or they may be sequestrated. Based on the volume and composition or the disc which is occupying the canal, based on third sort of percentiles, you can have mild, moderate, and severe, but this is radiological. The clinical correlation needs to be done. The location of the disc may be central. These are the ones which are likely to give back pain and crossed SLR positive. Posterolateral discs are the ones which come most commonly positive on SLR, and they also can be positive on crossed SLR and is the most common presentation. Foraminal discs may have SLR negativity, and extraforaminal discs, if they impinge on the ganglion, then they are the ones which give tremendous pain, and whatever you do, unless you sort of these patients are the ones which develop deficit very early and they have excruciating pain because there is no gating mechanism for these pains. Coming to the differential diagnosis, we have to consider the differential diagnosis as per the age of the patient. In young age, sacroiliitis, like in a case of ankylosing spondylitis, may mimic a lower lumbar radiculopathy. Usually, these are young adults presenting with morning stiffness, males. Infection in Indian scenario, especially tuberculosis, we have to consider. Tethered cord in children, growing age, they may present with back pain and leg radiation, and usually they have telltale signs like they have asymmetric weakness. Acute lysis, like in a case of injury, may also present similarly. Middle-aged females with pelvic pathologies can mimic lumbar radiculopathies. Nerve tumors like schwannomas can present with lumbar radiculopathies. Multiple sclerosis is one disease you should know about, and this is a medical radiculopathy, and the treatment is medical. We should not miss it in this age group. Elderly patients, they may present as a confounding factor to degen pathologies like degenerative spondylolisthesis, progression of curve, facetal cysts. Metastasis and malignancies are something which we need to rule out in this age group, and multiple myeloma is a common thing if it involves sacroiliac joint or they present as soft tissue masses within the spinal canal can cause such pain. The lumbosacral radiculopathy has many mimickers, and we should be aware about these, like a tumor or hematoma in lumbar plexus can present with a radiculopathy. Obturator neuropathy can present like an upper lumbar radiculopathy mimicking the internal thigh pain. Myalgia paresthetica, which happens primarily in mostly in females who suddenly have lost or gained weight, can present as a pain and paresthesias in the anterolateral aspect of thigh, mimicking upper lumbar radiculopathy. And similarly, peroneal neuropathy, like in case of trauma or sometimes in Hansen's disease, can present mimicking a L4, L5, affecting the peroneal compartment. Tarsal tunnel syndrome is an important pain generator, especially in patients who have flat feet. And piriformis syndrome, which we as surgeons do not believe much, but physiotherapists would say about them, can also present like a lumbosacral radiculopathy. Thank you very much.
That's a lovely talk, Agni. Very nice. So what is the sensitivity of the straight leg raising test? I mean, when you do a straight leg raising test and it's positive, what should the examiner conclude?
So it would imply that there is a lumbar root compression. It may not necessarily be a prolapsed intervertebral disc. It could be compression because of any other reason also, like a malignancy also. But it would imply that there is a lumbar root compression. The path of the root is shortened, and that's why when we are raising the leg, it is reciprocating the radicular pain which the patient is feeling in his leg.
Can a pelvic tumor which is compressing the sciatic nerve also cause a positive SLR?
It's less likely, sir, that a soft pelvic tumor will cause a SLR positivity, because usually the slack is more in the root area and in the upper lumbar area. But yes, if it is causing stretching of the nerve, like with a soft, sort of a solid tumor, which is more hardened and it is pushing the roots and the plexus away, it can result sometimes in a positive SLR.
And what is the significance? How significant is the crossed leg, straight leg raising test? Is
So,
it I remember that in the good old days, it used to be said that if you have a straight leg raising crossed SLR positive, it's either an axillary disc or a very large central disc, then you get that. But does it add to the specificity of your diagnosis?
yes, it does add, sir, because this is one of the most specific root stretch signs that we have. So usually whenever we do the test, we tend to choose the one which is highly sensitive first and then rule it out with a highly specific. So increased specificity in this test would mean that it will not come positive in all the cases. But in the case where crossed SLR is positive, the likelihood that the patient is not having a disc is very, very, very less.
Any other questions for Agni? Please unmute yourselves if you are any participant here or any of the other faculty would like to ask questions. Okay, I think Agni, you've covered it so well that people have understood. Let's go on to the next talk. That's the management of lumbar disc prolapse. I will be speaking about that. So now that you've understood the anatomy and function of the lumbar intervertebral disc and how to identify a disc prolapse on history, on examination, and on radiological imaging, it's time to decide about the management. So this 31-year-old manual laborer came to me a few months ago, 7-day history of severe back and right leg pain. He was unable to sit down, stand, or walk with comfort. There were paresthesia in the posterior thigh, calf, and sole of the foot. No bladder bowel complaints, no relief of anti-inflammatory drugs. On the basis of the history, I concluded that this patient had an right-sided S1 radiculopathy because of the distribution of pain and paresthesia. On examination, there was tenderness at L5-S1. The paraspinal muscle spasm was there. There was movement was restricted in all directions. The straight leg raising was positive at 30. With the straight leg raising is a fairly sensitive test to indicate sciatic nerve irritation. A crossed SLR makes this test far more specific, the diagnosis of lumbar intervertebral disc. So we did do a crossed SLR, which was positive. The power was normal in both the lower limbs. Sensations were normal. However, the reflexes were on the right ankle was absent. The Babinski was equivocal on the right side too. The question then arose is what is the diagnosis here? And I thought the diagnosis was fairly straightforward because I followed the McCulloch clinical criteria for lumbar disc prolapse. The pain must be a radicular leg pain, not a radiating or a diffuse leg pain. And that must be the dominant complaint, not back pain. The neurological symptoms must be in a radicular distribution, which means the paresthesia, the numbness, the weakness must be in a radicular distribution. The SLR must be significantly reduced, and the neurologic deficit must also be in a radicular distribution. This patient fulfilled all my criteria for a lumbar disc prolapse, and therefore my diagnosis here was obvious. It is a lumbar disc prolapse. The question in my mind now was, now that I've made a diagnosis, should I go for investigations? Should I go for an X-ray or an MRI? Plan non-operative treatment, or should I directly go for surgery? He has an absent ankle reflex. So what helps you here is to know the natural history of any pathology, because that is what guides your treatment. The natural history of lumbar disc prolapse has been well elucidated. 80% of patients improve with conservative treatment within 6 weeks. 90% improve within 3 months. But between 3 months and 1 year, only 4% more patients tend to get relief. So 3 months seems to be the cutoff period by which time a majority of the patients tend to recover. It is not that they don't recover subsequently, but the chances they may recover are far more poor after 3 months. 10% of these patients will have persistent pain or develop recurring episodes, and only 4% of patients require surgery for pain relief or for a neurologic deficit. What is the non-operative treatment? The non-operative treatment traditionally has been bed rest, traction and bells, medications, exercises, and epidural injections. Let us examine each of these treatment modalities. The fundamental basis of bed rest is it reduces inflammation. Bed rest was started in the days of Hippocrates, when there were no drugs which could reduce inflammation. Today, we have some fantastic anti-inflammatory agents, and these help in reduction of inflammation, and therefore the role of bed rest is being questioned. What does bed rest exactly mean, and how much should be the duration of bed rest? Well, the Sal brothers published a paper way back in 1989 that prolonged bed rest, which is given for sciatica, almost 6 to 8 weeks, results in physical deconditioning, loss of motivation, a negative calcium balance, and therefore they strongly advised against bed rest. A subsequent study showed that whether you gave 2 weeks of bed rest or allowed patient to continue activity within limits of pain, there was no difference in outcome. And further studies which looked specifically at acute sciatica showed that continuation of activities of daily living within limits of pain showed similar effectiveness as bed rest and physiotherapy. So today, bed rest for acute sciatica is no longer the standard of care. if at all, you give a short period of bed rest for 2 to 3 days till the acute inflammation settles down, and then you allow continuity of activities. Traction was started in the good old days. Some people thought that traction would enforce bed rest, but the other people thought that by when you give traction, it opens up the intervertebral foramina, it opens up the lumbar intervertebral disc, and therefore the disc may pop back into place. Well, there are some fantastic studies. CT and myelography has been done before and during traction for disc herniation, and it has shown no change in the size of the disc herniation. Today, there is absolutely no role for traction in the treatment of lumbar disc prolapse. Going on to lumbar supports, lumbar belts, etc. You just heard Sai talk about the fact that when the spine is loaded, the disc gets compressed and it expands, it moves out because it's a fluid gel. And that gel, then you feel the pressure in your back. To reduce that pressure and to increase the intra-abdominal pressure, beds have been used for centuries to help the patient relieve pain. However, if you look at the Cochrane database, there is absolutely no evidence in literature to support the use of belts or corsets for acute sciatica. Some patients say that they feel better when they use a belt. Do not stop them from using it, but advise them that it's not helping them in any way. When it comes to medications, the most common medications we use are anti-inflammatories. There is inflammation. I see a lot of people prescribing directly gabapentin and forgetting that the primary cause of pain is inflammation. Unless you treat the inflammation, the pain is not going to go away. So rather than giving gabapentin alone, give anti-inflammatories are your primary drugs for the treatment of acute sciatica. But anti-inflammatories have side effects, and to reduce the side effects and titrate the drugs, we add analgesics or neuropathic agents like gabapentin or pregabalin in order to reduce the dosage of anti-inflammatories that is required. The next thing to do that is questioned is muscle relaxants. So muscle relaxants relieve muscle spasm and help the pain. But your muscle spasm is because of inflammation and pain. So how will giving only muscle relaxants help? You need to give anti-inflammatories to reduce the inflammation and treat the basic pathology. Once you treat the basic pathology, the muscle relaxation will happen on its own. Therefore, the role of muscle relaxants is extremely dubious. Proteolytics like trypsin, chymotrypsin, fluogenzyme have been used, but they have not been shown to have definitive role. Steroids, of course, is one of the best anti-inflammatory agents known to mankind. However, steroids also have significant side effects. In today's day and age, when you have such fantastic anti-inflammatory agents, the role of steroids is questionable. Steroids were one of the first drugs which were introduced in modern medicine back in the 90s, 30s, and 40s. At that time, there were no good anti-inflammatories. Therefore, people used steroids as anti-inflammatories. In today's day and age, when you have such fantastic drugs, why would you use steroids? What about the role of exercises? Exercises actually relieve your pain by releasing endorphins. They prepare the patient for function and permit early return to activities of daily living. Sal brothers, in their paper in 1989, said that the failure of a passive non-operative treatment program with shortwave diathermy, IFT, bed rest, and medicines is not enough to decide on surgery. In their series, therapeutic exercises yielded a 96% success rate and faster healing than in Weber's series. 92% of their patients returned to work, a majority of them in their original jobs. So when should exercises be started? Early in the course of the disease, within limits of pain, is what the exercise is all about. What exercises? Should it be flexion? Should it be extension? Should it be yoga? What is the best kind of exercise? The key to success is activity in any form. rather than any specific exercise. However, in my practice, I have found that McKenzie type directional exercises are useful in relieving pain. I use them like painkillers. I tell them that rather than have painkillers, do your exercise 4 times a day. These will release endorphins and help your pain relief. What about epidural steroid injections? Well, obviously, it reduces inflammation. It helps to break the pain cycle. When the patient has a lot of pain, he is not able to exercise. If he's not exercising, the pain is not going down. Body becomes stiff, muscles become weak, and patient gets bedridden. You want to break this cycle of inflammation, and that's where the steroids come in. You have to have a clear understanding that inflammation in these patients is there in the first 6 to 8 weeks. And therefore, the role of steroid injections is in the first 6, 8 weeks, 2 months, 3 months. After that, there is not much inflammation. It is mechanical compression of the nerve, and therefore giving epidural injections just at that point in time has no role. The injections are meant to tide away an acute crisis. So I always tell the patient that when the injection is given, there is hardly any side effect, but there is no guarantee. Will it work? I don't know. If it works, how much relief will the patient get? I don't know. And if the relief is got, how long will it last? We don't know. So what are the routes of administration? We could do intralaminar like the anesthetists do. We could do caudal epidurals through the sacral hiatus, or we could go transforaminally. Typically, we use either betamethasone or methylprednisolone, and bupivacaine is what is commonly used. Here is a study which came way back in 2001. 30 patients with disc herniations or acute radiculopathy secondary to a lateral recess stenosis. They were injected with a root block, and 87% of these patients had rapid and substantial pain reduction. 60% had permanent resolution of pain, and operations were avoided in a large majority at almost 18 months follow-up. What about other non-operative treatment options? Chiropractic manipulations are commonly being used by people, but in acute sciatica, they are of borderline usage. For simple low back pain, they have been found to be useful. Acupressure, acupuncture cannot make the disc go away, but they can help some of the pain. Shortwave diathermy TENS is complete hocus pocus. Behavioral therapy is more useful in chronic back pains rather than in acute scenarios. Ozone therapy is more useful for simple disc degeneration than for prolapsed lumbar intervertebral disc. So what are the outcomes of non-operative treatment in terms of pain relief? Weber, in his famous study back in 1983, showed that almost all patients will get better either non-operatively or operatively. The advantage of surgery was that in the short term, the results were far better. But in the long term, at 4 and 10-year follow-up, the results between non-operative and operative treatment were the same. What about neurologic improvement if you've treated this patient non-operatively? About 50 to 70% of patients show motor recovery irrespective of the treatment modality. Most of the motor recovery occurs within the first month, and there is no difference at the end of 12 months between actually patients who have been operated or non-operated. Sensory recovery is always delayed. Poor prognostic factors, diabetes, longer duration between the initial symptoms and treatment, and if the patient has come with a functional neurological motor loss. If the patient has a grade 1, grade 4 EHL, I don't care. This patient's functional, he's not functionally disabled. The chances that this will recover neurologically is very good. But if the patient has a grade 0 ankle dorsiflexion, so he has a drop foot, then the chances of recovery are very poor irrespective of what you do. What happens as the patient gets better? One of 3 things happen. As time goes by, the water content of the disc reduces. So the prolapse fragment keeps on shrinking, and when it is shrunk down, then it allows the nerve to have more room and therefore the patient gets pain relief. The second thing that can happen is when the disc comes out, proteolytic enzymes are released by the disc, by the body, and they go and they attack the disc and eat up this fragment which has come out, which has extruded or sequestrated. Or the third thing that can happen is that the disc stays as it is over a period of time. It has been found that almost 75% of disc prolapses will reduce by 3/4 to almost full volume on follow-up scans. We all get very frightened when there are MRI images of large herniations. In fact, large herniations usually disappear more often than smaller ones like bulges and protrusions. And clinically, pain settles down much earlier than the actual reduction in the size of disc herniation on MRI. This patient of ours whom I talked about, the 31-year-old manual laborer, he underwent this entire gamut of non-operative treatment, but 2 months later, he still had persistent severe back pain and right leg pain. He had difficulty in standing and sitting, paresthesia in posterior thigh, calf, and sole, no pain relief with non-operative treatment, including epidural injections. There was tenderness, the SLR was positive, so was cross SLR. Sensations were reduced over S1 dermatome. What should we do now? The patient came to us with a MRI scan done, and you can see, as per what Agnivesh showed you in his lecture, that there is a disc protrusion, a large protrusion of the disc, which is there at L5S1 on the right side. The question now is, how should we proceed? Patient has no relief of pain. He still wants to, should we continue non-operative treatment? Should we consider repeating an epidural steroid injection? Do we need any further investigations, or should we think about surgery in this patient? We discussed, since the patient did not have a functional neurologic deficit, we had a lengthy discussion with the patient as to how he would like to proceed. A repeat epidural injection also offered to the patient, but he opted for surgery. So when should you think of surgery for lumbar disc prolapse? Why should you think for a surgery? Who are the patients in whom you should think? When should the surgery be done? And what is the type of surgery which should be done? Are the questions I'm sure that are plaguing you. Surgery is done because surgery allows immediate pain relief, provides excellent results in the long term. It does help immediate removal of pressure on the nerve, allows patient motor recovery and sensory recovery to start immediately. At long-term follow-up, non-operative treatment in the Cochrane database review had more back pain, more sick days, and fewer patients returned to their original work. Similar results out of the main spine study, where they too found that the advantage of surgery was maximum early during follow-up. What are the indications for surgery? The absolute indication for surgery is the acute cauda equina syndrome, which is then an emergency and one must proceed with surgery as early as possible. A progressive motor deficit or a deficit which is functionally disabling, like a foot drop, a quadriceps, significant quadriceps weakness, is something where we would think of surgery on an urgent basis. The most common indication, however, is failure of adequate trial of conservative treatment. A lot of doctors frighten patients by saying that if we don't operate, your neurology will worsen. That is a very rare thing to happen. The size of the disc herniation rarely ever increases in that same sitting. And whatever deficit is there usually is there at the beginning. It doesn't keep on worsening with time. What are the poor prognostic factors when you think of surgery? If there is leg pain which is produced by spinal extension, not by flexion, cauda equina syndrome, leg pain of more than 8 months duration, and less than 50% relief within 6 weeks of onset are all poor prognostic factors. Small contained disc herniations, which are bulges or protrusions, where the AP diameter is less than the transverse diameter of the disc fragment. Again, bulges and protrusions. small disc fragments, and patients in who have associated spinal stenosis. Other surgical factors, as William Bunnell always said, you must know about the patient who has the disease rather than knowing about the disease the patient has. So it is very important to know about your patients. Illiteracy, poor motivation, psychosocial issues, worker compensation issues are all poor prognostic factors. When should you operate? Well, if it's an acute chorda equina, a profound motor loss, one must try to operate as urgently as possible, preferably within less than 48 hours. If the indication for surgery is pain alone, then generally it is preferable to wait for anywhere from 6 to 8 weeks, because that is the time period when generally patients will have significant recovery. And you should operate before 9 months, because it has been shown that as time goes by, a persistent compression of the nerve results in gliosis of nerve fibers, resulting in irreversible neuropathological changes. And therefore, even after that you do surgery, patient may not get that much of a relief. What are your surgical options? Discectomy alone or decompression alone? Or should we do a fusion with every discectomy? There is absolutely no indication for routine fusion in a patient with disc prolapse. There are certain very classic indications. If there is associated instability or deformity at that disc segment, one may consider to do a fusion. Or during the surgery, if you have had to remove the complete facet on one side, you've created an instability, you might consider a fusion. What are your surgical approaches? One approach is that you do a fenestration, in which case you just remove the ligamentum flavum, the hypertrophied facetal capsule, and maybe a little bit of the bone in order to be able to see the nerve root and then excise the disc. The other approach is a hemilaminectomy with discectomy, a laminectomy with discectomy, or in recent times, one has started going through a posterolateral transforaminal approach endoscopically. So here is what we do in a fenestration discectomy. I was just telling you, we make a small hole, remove the flavum. This interlaminar space lies right opposite the disc, intervertebral disc. So retract the nerve root to one side and excise your disc. When should you consider a hemilaminectomy? If the disc has migrated upwards or downwards, then you might want to remove more of the lamina in order to be able to see the disc and remove it safely. When I was a young spine surgeon, I used to be always afraid of creating instability by removing more bone. Now I realize that it is much wiser to make sure you get a wider decompression, so that you don't have to decompress the nerve, retract the nerve root or neural structures too much, resulting in a post-operative burning, paresthesia, or weakness or numbness. Neurologic deficits are not reversible. If there is an instability, you can subsequently always operate and do a fusion. So don't be afraid of getting adequate exposure of your nerves, the dural sac, in order to do a generous discectomy. Other indications are discs with lateral canal stenosis, upper lumbar disc prolapse, or in patients who have conjoint nerve roots. Similarly, a laminectomy is still done. It's not that if you say I do a laminectomy with my discectomy, you are doing something horribly wrong. Typically in upper lumbar disc prolapses, in patients who have severe stenosis with disc prolapse or a large central disc prolapse, one would still think of doing a laminectomy. And in chorda equina syndromes, again, where a wide decompression is recommended, one would think of doing a laminectomy. Surgery in the good old days was done through a conventional open approach, and everything was seen below the eyes. As time went by, with MRI, we were able to localize the disc precisely. And we realized that opening up so much was not necessary, that this much of an incision, we could still do the surgery. The problem was that when you use small incisions, most of the OT lights got dispersed at the level of the skin. So you needed something which would deliver light at the depth of the wound. and that is where microscopes came in. Microscope's primary role is to provide coaxial lighting at the depth of the wound, and the secondary role is magnification. You then came after some years, people started saying that instead of stripping muscle off the bone, one should go through a muscle splitting approach, and therefore the tubular retractors came into being, and they are used with microscopes or endoscopes in order to do the discectomy. Today, the world has moved on. More and more people are doing endoscopic discectomies, either through a transforaminal or what is called as a posterolateral route, or through a typical interlaminar route, which is called as total endoscopic surgery. The advantages of the minimal invasive surgery routes are improved visualization. They allow magnification, less muscle dissection and bleeding, less pain, reduced hospital stay, and cosmesis. Limitations, of course, are many. I will not go into that. The final question which everybody asks is how much disc should be removed? Should we remove a fragment or a sequestrectomy? Should we do a subtotal excision as was done in the good old times? Or should we do fragmentectomy with exploration of disc for loose pieces? I think the jury is still open on this. There are lots of people, everybody does their own way. Generally, if in my practice, if there is a sequestrated fragment which has been there for some time, and I find that the annulus has no defect in that, then I do not make an incision. I just do the fragmentectomy and come out. But if the annulus hole is palpable, then I go in and I try to remove much of the loose disc as possible. So among the great mistakes in medicine are the generally belated ones, that some treatments are entirely useless. And then in the non-operative treatment of acute sciatica, we know that bed rest, traction, belts, muscle relaxants, steroids are generally useless and should be avoided. So what is my protocol for acute sciatica? We offer back rest rather than bed rest, hot water fomentation rather than shortwave diathermy or TENS, a combination of anti-inflammatories and analgesics. Exercises are started within limits of pain, and activity within limits of pain is allowed immediately as per tolerance. Epidural and root blocks are given in the acute stage to tide over the crisis, but return to work is only allowed after significant leg pain improvement. The primary goal of surgery is pain relief by decompressing the nerve root. I do not like to call the procedure a discectomy. I would rather call it a decompression. Sometimes there is an associated lateral recess stenosis. You must decompress the nerve root, otherwise just discectomy will not help this patient. Surgery must be done for lack of non-operative response to non-operative treatment, for progressive or significant motor weakness or cauda equina syndrome. Today, the literature shows that the long-term outcomes of the various discectomy procedures, whether you do open, whether you do micro, whether you do tubular retractors or endoscopy, is exactly the same in the long term. And therefore, my saying that the decision to operate is far more important than the incision itself. Thank you very much. With that, I stop this talk, and I'm happy to take any questions from any faculty or from any of the delegates.
Gautam sir, 2 questions are there in the chat box.
Yes.
Whether you would like to answer yourself or you would like to pass to one of the other faculty.
I didn't see. What is the question?
The question number 1 is what is the mechanism of the crossed SLR? And
I think
the
Agni
second,
should answer that question. Agni,
go ahead.
Yeah, so the mechanism of crossed SLR is that a significantly large central disc, or the one which is compressing the root significantly, the root is so much tented that it has completely taken away the slack or the mobility of the root. And when you stretch the contralateral leg, the stretch is going to pass on to the ipsilateral side also, which reproduces the pain in that radicular distribution. So this is the mechanism of a crossed SLR.
Second question is, can we diagnose a conjoint nerve root on MRI? And if yes, then what will be the telltale sign of a conjoint nerve root?
Yeah, Agni, what are the telltale signs? How do you diagnose a conjoint nerve root?
With the advent of these new 3 Tesla and good MRIs, you can actually preoperatively also find out if you take thinner sections and the reconstruction, 3D reconstructions, which the newer softwares allow, you can find out. So you can have an empty foramen sign. So in one of the foramens, you do not see the root, then it is one indirect sign that there might be a second root somewhere, or it may be a low-lying root or a conjoint root. Sometimes you see them as a foraminal muck which is separated from the disc. So this sometimes is like a furcal nerve or a root which is intraspinal conjoint, which means there is a communication between the adjacent roots intraspinally. And sometimes if you are lucky on the MRI, you can see two rootlets in the lateral recess, which would be represented as two round structures, and you can go into the surgery sort of prepared that you might find something which is abnormal there. But nevertheless, whenever you're operating on any patient, as Gautam sir has also beautifully said, that the decision is more important. So your planning is important, and always you start from the shoulder of the root. That's why it's essential to see the shoulder of the root, because if you start at axilla or somewhere, you don't know whether there is something else also laterally. So look at the MRI and always be prepared with surprises during the surgery.
Right. Saijyot, Sai, there is a question from one of the participants that when you start the surgery, you've seen the MRI. The MRI seems to show a very large disc fragment. But when you go inside, sometimes you find a much smaller disc fragment. How do you explain that?
Yes, sir. So basically, whenever we see a large segment, so we first confirm with the MRI that if the MRI is recent or not, first of all. If we see the MRI is recent and the findings are also recent, and we confirm that the disc is large on the MRI, then we definitely, if we do not find it on the intraoperatively, we will definitely look for it. And we will obviously know the location of the disc on the MRI after seeing it, and particularly that location will search, and we'll also go and see the other places. If not, then only close and come back.
Right. So I think that is a very important message for everybody, that make sure that you get the disc, it gets progressively shrinks with time. And therefore, an MRI which is 2 months old in a patient in whom you are doing a discectomy now may not be valid. So make sure that you make sure that your MRI is fairly recent. And if you still see that if the MRI is recent, and then it behoves you make every effort to make sure that there is no disc fragment left behind.
Gautam, I think the main thing is sometimes is there is sacralization of L5 and the counting with X-rays, and the counting on MRI is very different. So that is the time I think a lot of mistakes happen. So always see which is the first open space from below and then count, so that you are not at the wrong level.
Right. So wrong level surgery is something which is not uncommon in spine surgery, especially in the good old days when people used to not be reluctant to use Shyam. Today, with a lot of people doing minimally invasive spine surgery where precision is everything, everybody is doing the surgery using Shyams, and therefore the chances of wrong level are much lesser if you are very meticulous about your work. Another thing that happens, Srinivas, is that a lot of chronic discs, when you see on MRI, you think this is a huge disc, but actually there are more osteophytes and there is annular deformation. The actual fragment of the disc is not very large. So therefore, you may feel that it's a large disc, but when you open up, you'll find there are large osteophytes there, and that is why I said that decompression is the goal of surgery and not only discectomy. Any other questions, Amit?
Yes. From Dr. Ajay Veer, that will use of bipolar cautery on the disc will shrink its size and maybe prevent subsequent herniation.
Right. I have no experience at all with using bipolar cautery on the annulus. Any of the faculty, Agni, Sai, or Amit, Devesh, Satyen, whoever is there, if you have an explanation, please answer.
So, sir, it is probably done with an intent that using the bipolar cautery on the margins of that annular rent, it will harden the tissue and make it less amenable to sort of giving way to a hard disc. But whether it actually translates into a clinical scenario where it prevents a disc prolapse, I don't think there is an answer to
I
that.
think they used to have for fissures, they used to use bipolar, but it has failed. I think it is supposed to collagenise the disc. The collagen is to stiffen the annulus, but I think it has not worked. Long-term results.
Gautam, sir, I have a question.
Yeah, tell me.
So this comes as a dilemma to me. You have a patient who is admitted with you with severe pain. You are giving whatever medications you can, doesn't have a deficit to begin with, but the pain is unbearable. And suddenly, then what happens is that patient develops a partial deficit. The foot becomes weak and the pain also reduces. Now, this becomes a dilemma now because the deficit has come, should we operate the patient? And because the pain has reduced, what is the point of operating?
Right. So this is it's a very good question, Agni, because sometimes what we can offer the patient is definitely pain relief. What we can't promise the patient is neurological recovery. And therefore, if the patient's pain is already less, your indication for surgery has gone down a little bit. But on the other hand, patient has developed a fresh deficit. So if it's a mild deficit, so grade 2, 3, 4 power, then I would suspect that if the pain is going down, you treat this patient conservatively, the neurologic deficit will improve. But if it's a functionally limiting deficit, then certainly something which I would like to go in and operate. And there I have to explain to the patient that you have a significant deficit, though your pain has gone down, and we would like to operate from the deficit point of view. Even so, I cannot guarantee a neurological recovery.
Right.
Another radiological question: how to identify hard disk as compared to the soft disk, and does it affect the decision making for surgery?
Sai, would you like to answer that?
So basically, on an MRI, whenever you see a low signal intensity on both the sections, that time you can think of it as a hard disk rather than the soft disk. A soft disk which has nucleus pulposa will always have a high intensity. And about the second part of the question where it says affect the decision for surgery, intraoperatively, whenever I find a hard disk, if I see if it's a very hard disk, I just let it be. We don't try to break into the hard disk and try to disturb the disk there. And with only foraminotomy and just releasing the nerve there, we just let it go.
Right.
Gautam, one question.
Satyen, there is a question here, which is the best approach for a epidural steroid? Is it caudal, interlaminar, or do you decide on a patient-to-patient basis? Satyen? Unmute yourself. Satyen, you need to unmute yourself.
Gautam, one question.
Yeah.
Very often we see multiple discs on the MRI. How do you know which one to operate?
That's a very good question. So I'm going to ask you that question in a few moments, Devesh.
Now, Satyen sir,
As we go
now
on
so
to
you can try.
now, Satyen, you are on. So tell us something about epidurals. How do you decide your approach? Will you go
So-
interlaminar? Will you go transforaminar or caudal?
Yeah, so it depends on patient to patient, depending on the type of disc herniation that is present and causing the pain. So if it is a lateral recess disc herniation or even a extraforaminal type of disc herniation, I just go transforaminally up to the root which is getting affected and just give the epidural steroid on that root. However, if it's a large disc or a central herniated disc, then you may want to do an interlaminar approach because that would give you a better diffusion in the area.
Right.
Sometimes these patients have bilateral symptoms, so then again you can add both. You can do a transforaminal along with an interlaminar as well.
Right. So sometimes also what happens, Satyen, is that they are very large. You want to give an L5 root block or a transforaminal epidural, but they have large, thick transverse processes, and there is hardly any space for you to enter this thing. So how do you manage that in epidural? Do you then shift to another form of epidural injection, or do you still try to go through the same place?
So if you get your technique right and position your C-arm in such a way that you can go parallel to the end plates and then try to get in there. If you're able to get in there, then nothing like it. Otherwise, just give a interlaminar.
Right.
epidural.
I have started giving more and more of caudal epidurals. The caudal epidurals were initially shown to be, there was some worry in the minds of people that if you give a caudal epidural injection, that the drug would not go to the level at which you are operating. However, that has not been my experience. The advantage is even if there is Bertolotti syndrome, large transverse processes, decreased disc space, even if there are implants in a previously operated patients or scarring, you can still do a caudal epidural very well, and the success rate is very good. So I am doing more and more of caudal epidurals nowadays whenever there is even a limited scope for.
Also, sir,
I have never ever in my practice done interlaminar epidurals. I have always done either transforaminal epidurals. The advantage being that L5 root is involved, you are giving injection around the L5 root and then entering the epidural space. So you get relief of the pain of the L5 root and whatever else inflammation is there within the same. So that's what I've been doing.
There's one problem, sir, that if you're giving a caudal, you're much closer to the anal cleft. So there is, theoretically, a higher chance of maybe causing an infection, although it is not very documented.
So, yeah, it's not. I have now given more than 300-400 caudal epidurals. I've never had a single infection. So
one clinical question. So if you have planned for a disc removal discectomy only, and intraoperatively you found that while removing the disc, you kind of end up removing a lot of disc, and you leave that, you are left with that empty space inside. So how would you proceed? Like, would you be kind of, would you feel that you should have kept
I would not feel the need. So, Selva, this is not an uncommon problem. You do it, especially in the good old days. Now we do less, Srinivas. Now we do a less and less of more aggressive excision of the disc, unlike in the good old days. But in the good old days, we used to do that. And we never stabilize these patients, neither fusion nor interbody fusion nor instrumentation. And they all, in fact, the disc space settles down with time and achieves an auto stabilization of that level. And I don't think that is something which we should be concerned about and start fusing for that indication.
I have a question. So there was one discussion earlier on if you open up and you see that there is you can't get the justification for a discectomy, it does not correspond with the MRI. So we've had a few cases, and I wanted to know your opinion, where the disc fragment has been pushed away during the opening to the opposite side, and also some cases where, especially Amit also knows about it, where there was an intradural disc herniation, and that's why we were not able to see it on the, when we opened it up. Your experience on that?
So I must say that in 25 plus years of practice, I have never seen an intradural disc herniation. But I'm sure it is reported very well. People have seen what happens if it's a chronic large disc herniation. It eventually causes thinning of the dura, and then there is a dural defect and the disc goes in. So yeah, and then the dura may heal on its own over there. So you can get intradural disc herniations, theoretically possible, practically seen. You should be aware of that possibility. Something which I would not normally advise on such a large forum. But since you specifically asked me this question, if I don't find a disc then I will actually, in the lower lumbar spine, I will actually put my hand on the finger on the dura and try to palpate the disc in the dural sac and see if that what you have described in intradural herniation is there or not. So yes, that is, you should look for it. Sometimes you will feel a hard mass within the dural sac itself. Does migration to the opposite side after, I mean, you've done a fairly fresh MRI and then you pushing the disc to the opposite side, physically when you are doing the discectomy, possible, yes, especially when you are doing, what more likely happens is in migrated discs. When the disc has gone migrated upwards or downwards and you put in a cotton patty to retract the dural sac and nerve root, you might actually put that push that sequestered fragment further up or further down. So that can happen. Yes, it's theoretically possible. Yeah. Okay. So there are still a lot of questions.
Yeah, Gautam,
Bolo na.
how do the different types of disc and how will you get to it? Central disc, posterolateral, foraminal, and extraforaminal.
Okay.
How does it differ?
So I think that's what I was about to say. We should move on to the case series because all this is being discussed there.
Okay.
So
Fair enough.
yeah. So first case, there is this lady. I can't see my. Who had lifted a bucket of water in the morning. She had some low back pain. By afternoon, she had severe pain in both legs. By evening 6 p.m., she was unable to walk. The spine was non-tender. The SLR was positive bilaterally. She had retention of urine, had to be catheterized. On catheterization, 800 ml of urine came out. Her anal tone was fair. There was grade 0 power in the left EHL, tibant and peroneal, and grade 1 power on the right side. She had grade 3 power in bilateral quads and hip flexors. There was anesthesia in the left L45S1 and 50% hyposthesia in the right side. Diffuse reduction in sensations, and bilateral knee ankles were negative and planters were not elicitable. What is the diagnosis here? Sai, any clues to the diagnosis here? What would you call this condition?
Yes, sir. So I can see patient had a low history of low back pain since 15 years, and suddenly when she had a very episode of things which is not used to lifting a bucket, she had severe leg pain and weakness, which is neurodeficit. So I would say it is a chronic degenerative disc which was giving a pain, which has led to a fresh annular tear and a large disc bulge causing neurodeficit plus retention of urine. So I would also definitely immediately investigate, and it's a cauda equina case here.
Absolutely. So this is an acute cauda equina syndrome. In an acute cauda equina syndrome, patient complains of back pain, typically unilateral or bilateral sciatica. There may be bladder or bowel disturbances, reduced sensations in the perineum, erectile dysfunction, and gait disturbances. The cauda equina, for all the young boys who are seeing this, is the part of the when the spinal cord ends at the conus medullaris at L1. Beyond that, the nerves come out individually, and this bunch of nerves is called as the cauda equina. An acute cauda equina syndrome is seen in about 1 to 1.5 people in 1 lakh population per year. An acute cauda equina syndrome can be classified into 3 types. The one in which there is no sphincter dysfunction. The primary complaint is numbness in the perineum or bilateral sciatica. The second kind is an incomplete cauda equina syndrome where there is more of dysuria, urgency, altered sensation. And the third type is a complete one where there is painless retention with overflow incontinence of urine and stools. So this patient seemed to have an acute cauda equina syndrome. We got x-rays done. You can see there was some focal kyphosis in the upper dorsolumbar junction. This was the MRI. As you can see, at the D12L1 level, there was a cyst within the spinal cord. At L12, there looked like a small disc bulge or a disc protrusion with mild narrowing of the canal. At L34, what looked like a protrusion. At L45, another disc protrusion. And 5-1, there was just a disc bulge. Now the question here was, which is the offending level? And so let's go back to Devesh. Devesh, which is the offending level over here, you think? Is Devesh around? All right, let's move to Satyen. Satyen?
Unmute, yeah, sorry.
Okay, Devesh.
Hello.
Yeah.
I think this person also has hypoesthesia and L1, L2, L3 dermatome also.
Mild
Along with-
hypoesthesia L3-4, yeah, 2-3-4.
Because the main component looks at L3, L4-5. I think that area looks at IC1, where is a large sequestrated fragment.
So this
We'll
is
have
the
to tackle
fragment that Devesh is talking about,
Absolutely.
which
Yes.
is the sequestered fragment which has migrated upwards from the L4-5 disc. There is a small disc protrusion at 3-4. So you think the 4-5 is the offending structure?
Absolutely.
And now this is of course a cauda equina situation, but if this was not cauda equina situation, patient just coming with severe sciatica, what would you do in order to establish whether the problem is from 2-3, 3-4, 4-5, 5-1? How will you go about? Or will you attack all the levels?
So first, you look at clinically what dermatomyotomes are involved. Second, you would like to do an EMG nerve conduction study to confirm where we are. Third, if you're still not sure after all these investigations, you can do a selective root block to find out the area which is the cause of the problem. And you
Right.
can tackle it singly or you can attack all the levels depending on talking to the patient.
So how should we proceed here? Further investigations in this patient, should we go for an EMG nerve conduction and a root block, or she has an acute cauda equina syndrome? Should we think about non-operative here, or should we directly jump in with surgery?
I think cauda equina is an emergency. At best is to operate as early as possible instead of waiting.
Right. So the role of EMG nerve conduction study, as Devesh mentioned, it is a great test for differentiating demyelinating disorders, diabetic neuropathy, but it has no significant reliability in identifying which is the painful nerve root in a patient with multi-level disc prolapse. And therefore, role of EMG nerve conduction study is dubious. What has, however, helped is what Devesh mentioned, the diagnostic root blocks. When there is what Anderberg said was that there is a poor correlation between pain distribution, neurology, and degeneration on MRI when deciding the affected nerve roots in patients with radiculopathy and 2-level degeneration. They found that nerve root blocks, when correlated with all these above parameters, offered excellent diagnosis of the pathological level in multi-level disc prolapse. Another study by Sasso et al. Again, similar results, good results correlated with root blocks after surgery, then with MRI. Timing of surgery here, Satyen, what about the timing here? What do you think? When should we go in?
Yeah, this is the only indication where you actually have to take the patient in on emergency basis. So ideally, I mean, if you are able to do it within 12 hours is great. But practically, we also have to see, when the patient comes in, we need to get the patient ready for surgery. So if we are doing it within 24 hours, it is still supposed to be quite good. But if you purposely delay it beyond 3 days, then medico-legally it could be a problem for you. So as soon as possible, ideally within 24 hours.
But suppose in a lot of our patients,
They come
after
in
you've
late.
told them everything, they take their own sweet time to decide in India. And by then it's almost 2-3 days gone. So if 3 days are gone, should you tell the patient now that I don't want to operate on you, it's too late? Or should we still go ahead and operate, and what should be the
Most of the time they present also late. Many a times they come only after 3 days or 4 days of having the problem. So we need to, of course, have a detailed discussion with these patients. If it is a partial cauda equina or a developing type of situation, then definitely go ahead and do it. And we need to, of course, the chances of recovery, the prognosis gets better. However, if it is a complete cauda equina, you will still go ahead and do it, but you need to explain to the patient that the chances of recovery will be lesser, or you need to give a good, detailed discussion on the prognosis.
Right. Agni, what surgery here? We've said now we can see that at L2, L1, so a bit L2. So L1, 2, there is a disc protrusion. There seems to be some stenosis. Above that, there is a cyst. Does it require an exploration? 3, 4 is showing you a protrusion or an extrusion, whatever you want to call it. 4, 5 has the sequestration. So what year should we tackle now? What will be your surgical plan in this patient?
Sir, before I say that, I just want to reconfirm that above L4, you said the neurology was normal, hip and knee extensors were normal.
So the power seemed to be reduced. There wasn't, the hip was not grade 5, it was grade 3, but it was difficult to make out whether it was because of the severe pain or whether there was an actual deficit. There was no clear-cut sensory loss about the day, but there was a diffuse, yes, sir, it was,
difficult to
thoda kam samajh raha hai, but not very clear. Like she was definitive about L4, 5, S1, where there was very clear sensory loss, anesthesia on the left, hyposthesia on the right. That was not the picture at L2, 3.
So, sir, because these discs, these above L1, L2 bulges, they have been there before also. She had been living with it, with chronic back pain. My intention here is to set the offending thing right at this point of time, which is this extruded disc which has come out. So I would not want to tackle everything, including that intradural cyst, because it's maybe just an incidental finding. She must have been living with it for years. I don't want to correct everything at this moment, but my surgery here in an emergency situation would be limited to what is offending right now. And that is this extruded disc fragment which has come out.
Right. So it would be a laminectomy with a discectomy or what? And if laminectomy, which lamina, which disc, everything. Tell us a little bit more details about your plan.
Right. So if I'm not wrong, or based on these limited MRIs, it's the L3-4 disc which has inferiorly migrated, right, sir?
So we think in this limited, it's the L4-5 which has migrated upwards.
Right. And her age is 60.
Yeah. 49 or 59.
47.
So 47. So young patient. So my aim here would be to do a laminectomy of L4 and partial laminectomy of L5 because L3, because that is where this disc is residing. So to remove this disc, we'll have to remove this complete L4 lamina. We cannot spare that. And if I end up destabilizing the lateral facets more in order to safely try to remove this disc, then I will have to add a fusion at this index level.
Will you tackle the 3-4 disc at all? Will you go and explore it? Will you go and excise it? Or
I will explore it, sir, because I am anyways entering that area, but I would have a very, very high threshold to sort of incise it and try to remove everything from it. I would just decompress the roots and come out from there.
Right. So the outcomes of surgery for lumbar disc prolapse in cauda equina syndrome, significantly better outcomes if surgery is performed within 48 hours. But even when the patient is operated after 48 hours, up to 1 week, there was significant improvement, not only in pain, but also in motor recovery, recovery of urinary incontinence, rectal function, etc. So the take-home message here is cauda equina syndrome, my friends, is an absolute emergency. Early diagnosis is vital. We must know the symptoms: back pain, bilateral sciatica, perineal numbness, hyposthesia in the perineal or perianal region, loss of urine control, loss of bowel control, and gait disturbances. Surgery should ideally be done, as Satyen mentioned, as early as possible. However, if the patient, for whatever reason, has presented delayed or has taken a longer time to take the decision, then results up to 1 week are still good in terms of neurological recovery. The goal, as Agni mentioned at the end, is a wide decompression of the neurological elements without causing any further iatrogenic injury. If need be, remove more bone and stabilize rather than trying to do less and causing more neurological damage. Let's move on to the next case. This 43-year-old male had a sedentary job, no medical comorbidities, grumbling back pain for 3 months. Onset of severe back pain only for the last 3 days. He had bilateral buttock pain, no radicular leg pain, paresthesia, numbness, weakness, no bladder bowel affection. Patient was unable to lie down comfortably. Forward stoop posture with flexion of the hips and knees, loss of lumbar lordosis, severe spasm. Movements were painful and restricted. SLR was resulted in severe back pain, a diffuse kind of leg pain, which they were not able to quantify that. SIST hips pulses were normal, neurology was normal. The question is, how should we, Sai, how should we proceed over here? Should we go immediately for an MRI scan? Do you want to try non-operative here, a caudal epidural maybe, or should we think about surgery?
So now, before investigating, it's an acute episode, and he also had a previous history of back pain. So first, I would like to investigate now, because he has radiating pain and his activity of daily living is also affected. His
So
pain
this is the MRI we got. Now what? So you can see it is showing a massive central L4-5 disc with the canal occupancy of the disc being more than 50%.
Okay, so this is a large central disc now, which is causing his symptoms. But still, because now it's a acute disc and acute symptoms, we would also like to give him a conservative trial and wait for it. So conservative non-operative trial, sir.
So these are the zones of disc herniation. The disc could prolapse centrally. The disc could prolapse laterally in what is called as the lateral recess or the subarticular region. It could prolapse in the region of the foramen or what is called as an extraforaminal disc. In this case, it's a central disc herniation. Large central disc prolapses are common in the 35 to 45-year age group. Typically, patients are of high body mass index, and it is supposedly more common in those who are doing a lot of heavyweight lifting. Two types of disc prolapses are seen: central mass prolapse, which is an extrusion or a sequestration, or a contained disc herniation. Most patients will come with back pain. People may have unilateral or bilateral radicular leg pain, paresthesia, numbness. Cauda equina may be there in 43% of patients. They generally respond to non-operative treatment also. As Sai mentioned, my first choice would be non-operative. The surgery is for non-responders, inability to tolerate pain or neurologic deficit. So Sai said we should treat this with non-operative treatment or at the most with an epidural injection. So that is what was done. Patient was actually advised surgery, but the patient refused. And when he presented to me a little later, significant resolution of back pain. There was no leg pain, weakness, there was a mild sensory loss in the S1 distribution bilaterally, no bladder bowel incontinence. The follow-up MRI is like this. You can see there is almost a complete resolution of the intervertebral disc prolapse. Looks almost like that the original disc was a central disc. This almost looks like it's a lateral or posterolateral disc prolapse. But this is what happened to the patient. Patient did very well. If you look at the treatment, in a number of studies, it has been seen that most patients do respond to non-operative treatment, even with large central disc herniations. By 2-year follow-up, significant reduction is seen in the size of the herniation. The long-term clinical outcome is good for both back and leg pain. None of the patients have progressed. So we frighten these patients and tell them you'll develop cauda equina, you'll happen this, but nothing happened. None of them have actually progressed to develop cauda equina syndrome. And they concluded that sequestered discs resolve better than protrusion. Now, suppose there is failure of symptom resolution here. Devesh, what would be your surgical plan in this patient in case you had to go ahead with surgery? Yeah, Devesh. We can't hear you, Devesh.
Itself.
Yeah.
It's a young patient, probably
Yeah.
looking at the disc above and below. It's a posterolateral disc, central and posterolateral disc. I just do a fenestration and discectomy.
You would do just a fenestration of discectomy. A lot of people are worried that these heavily built individuals, when you do a fenestration discectomy, the risk that these patients will develop severe chronic back pain is higher. Is that something that has been your experience?
Yeah, if you are going to be into gymming or you are a lot into heavy labor, probably you may fuse such cases. Otherwise, it's best if the patient is young, I try to avoid fusion because again the problems of adjacent level disc prolapse is also high in such patients.
Devesh, here the disc appears almost purely central. Are you worried that when you do your fenestration discectomy, the amount of retraction you'll have to do in order to reach the disc space, patient may land up with a neurologic deficit?
As
Would
you
you
rightly said,
consider
that it's better to
removing
air
more bone or facet, etc., in order to reach the disc fragment?
At L4-5, the roots are quite mobile as compared to the higher disc. So you will be able to get to the disc by retracting the root. It shouldn't be a problem. But if you can access a part of do a more lateral part of the facet excision and get to the disc.
Okay, Satyen, what would be your approach here? Similar to
Yeah.
what Devesh is
No, I mean, I would be very, very tempted to do a fusion in this patient.
Right.
Of course, any decision has to be taken along with the patient. You have to discuss this with the patient and explain to him. My problem is that if I just do a decompression, there is a chance of higher chance of recurrence, a lot of chance of back pain, and him grumbling with back pain. He's been having it for years together, and him being in general unhappy. Whereas if I do a fusion, then there is a chance that he may develop adjacent level segment degeneration, which may happen maybe 5, 10, 15 years down the line. So it will be a discussion done with the patient in detail, because this is not a very straightforward case. Just go in and do a discectomy.
Right.
This is
So
not a
this
case.
controversy has been endless for large central disc prolapses. So in the good old days, studies recommended discectomy plus fusion because it would allow you to do a general facetectomy so that discectomy can be done safely. A large annular defect, as Satyen mentioned, there is a higher risk of recurrent disc prolapse. There is a higher incidence of low back pain in long term due to a large annular defect and larger volume of the herniated disc. So all these were the arguments for doing a discectomy and fusion. But a paper from our very own Dr. Arvind Kulkarni of the Bombay Spine Society, which was published recently in 2019, said that there are excellent outcomes with discectomy alone in 85% of patients. Fusion only for pre-existing instability or for severe degenerative changes. Both interbody fusion and posterolateral fusion had equally good results. So to conclude, large central disc prolapse, 3/4 of the patients respond to non-operative treatment. There is a significant reduction in size of disc on follow-up MRI. A long-term clinical outcome is good for both back and leg pain, and routine addition of the fusion to discectomy is unnecessary. We'll now move on to the last case of today. This patient came to us with a severe pain in the left leg radiating along the anterior thigh for the last 3 weeks. Patient had paresthesia, burning, numbness in the same distribution. Pain increases with standing and walking, but there were no bladder bowel issues, no relief with rest and NSAIDs. They had tenderness in the lumbar spine, flexion extension was reduced. The femoral stretch test was positive. There were quadriceps were weak. Sensory loss was there at left L3. The quadriceps reflex was absent. An MRI was done, and this is the picture that was seen. Agni, how would you call this? Classify this?
So, sir, I would label this as a primarily a foraminal disc herniation with some part going into extraforaminal space also.
Right. So as I showed earlier, there are 4 types based upon the central to lateral location. There is a central disc, there's a posterolateral disc, which is in the subarticular region. This is within the foramen, or there can be a disc which is still further laterally, which is called as a foraminal disc. Lateral disc prolapses are seen in constitute about 7 to 10% of all lumbar disc herniations. They can be foraminal or extraforaminal, which is called as far lateral. There are migrative fragments in about 50% of these patients. The most common level for lateral disc prolapse is L4-5, and neurology is seen in about 75% of these patients. The question here is, how should we proceed? So, Sai, how would you tackle this patient?
So, sir, this is a foraminal disc for sure, and patient is in a lot of pain. But seeing the history, I don't think he has any neurologic, or if I have missed it.
No, he has femoral a quadriceps weakness of grade 4 and sensory loss over the L3, L4.
Okay. But if the non-operative treatment are not working, but I would like to give him a root block.
Okay.
Because it's in the foramen, I think the root block would work for him if he's not responding to non-operative treatment.
So the outcomes of non-operative treatment are fairly good with lateral and far lateral disc. 71% of them have resolution of pain, sensory and motor deficit at 3-year follow-up, and only 5 of these patients required surgery. And as Sai mentioned, that even root block injection does brilliantly for these patients with a lateral or a far lateral disc prolapse. They do get good relief of pain. Now, unfortunately, in spite of all this, the patient did not get relief of pain. What would your approach be over here, Devesh? How would you tackle this? Devesh? Satyen?
Yeah, so I mean, there are 2 ways of doing this. Actually, the best way to do this would be by a transforaminal endoscope. You can just put the endoscope in and it will be directly on the disc and do a discectomy. I don't do the transforaminal endoscope, so I could just go in directly from either a Wiltse approach, but I suspect that it's not lateral enough for a Wiltse approach. Then I may just go in through our normal traditional microlumbar approach and tease the disc out, and it comes out quite easily if you do that.
So you should be able to, you think you'll be able to tackle it through a transforaminal, I mean a regular discectomy approach itself here.
Yeah. Or you can just go from the opposite side and remove the disc. You can get it out easily.
Yeah. Devesh, are you back? Devesh?
Yeah.
Yeah.
We can do
Is
through a
this something
standard
where you
approach.
could do through a tubular discectomy from the opposite side? So you put in a tube from the opposite side and reach the disc. Would that be easier in this patient?
I think it is a difficult situation. It's possible, but it's difficult because
Okay.
L3-4 space is already very tight compared to L4-5 and L5-S1. You can go through a standard discectomy incision, but you may have to work more laterally, so you have to require backward disc forceps to remove it. And if required, if you're not sure about a completeness of the discectomy, you can do a fascectomy and fusion if you're removing the facet, because L3-4 is very tight compared to L4-5 and L5-S1. So you start with a lateral standard approach and you should be able to do it. most of the
As
time.
Satyen said, that this is not the ideal case for a Wiltshire, a far lateral approach. A disc which is slightly more lateral, a far lateral disc is what we would do. What is the Wiltshire approach? Instead of going through the midline, you do a muscle splitting approach going slightly laterally. Longitudinal separation between the multifidus and the sacrospinalis. And you directly land. This is the incision. It is done at the tip of almost the transverse processes. And then you go inwards, splitting the muscle, landing up and on in the intertransverse area. As you can see, the medial retractor is placed above the facet joint onto the lamina so that you can explore that area well. And this is what you will see from the way you are going. This is the transverse process going into the lateral facet here and the lower transverse process. And this is the intertransverse membrane or ligament. So you have to expose that. Then you erase the ligament from the lateral aspect, from the lower part of the transverse process. And then you start burring over here and thinning it out, because this is where the nerve root is going to come out. Having taken the intertransverse ligament down, you'll see the nerve root, and just in the inferior to it will be the disc. You go in and do a disc removal, and the nerve root will be free at the side. The intertransverse approach is advantages. It allows direct visualization of disc prolapse. There is minimal handling of the nerve tissue or retraction, minimum bone or soft tissue removal, spinal stability is maintained. The problem is the alpha S1, it is not possible to do an intertransverse approach. As Satyen mentioned, the ideal surgery for something like this would be an endoscopic far lateral transforaminal discectomy, which would allow you a good result. So to conclude, a far lateral disc prolapse commonly involves the exiting nerve root. L4 root is involved with L4-5 far lateral disc. The Wiltshire intramuscular approach offers the best exposure of the far lateral disc whilst retaining stability. There are a number of other approaches. The problem usually is that although 80% of patients get good to excellent result, because of irritation of the dorsal root ganglion, often patient complains of persistent burning, leg pain, or paresthesia. I'm going to skip this case and I'm going to go to the last case I want to show. So this 21-year-old male came to me, severe back pain, bilateral posterior thigh pain, left greater than right since 4 months. No pain relief in spite of bed rest, traction, or anti-inflammatories. There was tenderness, spasm, movements were reduced in all planes, SLR, SIST, hip movements, everything was painful. Neurology was normal. These were the X-ray pictures that the patient had. The patient was seen by an orthopedic surgeon and advised an MRI scan. The MRI scan, on the basis of which he was advised a discectomy. He then went to a physician who said, no, this is tuberculosis of the spine, and put the patient on empirical AKT. When I saw the patient, there was a history of 4 kgs of weight loss. Pain was continuous and severe. It was worse in the morning. There was a pronounced limp when walking. On the face, there is a weeping pustular rash. You could not look at the face. He was so ugly. Direct tenderness over the sacroiliac joint and inability to sustain an active straight leg raise. I got an MRI of the sacroiliac joint, and look at this. The patient had severe sacroiliitis. This was a patient who had, this was the first presentation of Angstpond in this patient. I put the patient on steroids to reduce the inflammation, and lo behold, the entire face cleared up and all the rash went up. A lot of these rashes are very well known in autoimmune conditions. This is exactly what the patient had. So I just wanted to give you this case to tell you that every time you don't see a disc, don't start imagining a disc. Look for rule out other pathologies which can mimic the disc. With that, I would like to end this session. I would like to thank Devesh, Dr. Satyen Mehta, Dr. Agnivesh, Dr. Saijyot for coming together today as faculty. I would like to thank the OrthoTV people for being here today and helping us through this session. And I would like to thank the conveners of this session, Dr. Kshitij Chaudhary, Dr. Amit Sharma, and of course, Satyen, who's already on the panel. And I will end by playing these few slides again. The next Bombay Spine Society meeting is going to be on 7th of March, which is a Thursday, on evaluation of the spine. Dr. Kshitij Chaudhary will cover the history and examination of spinal problems of the spine. Dr. Uday Pawar will talk about MRI scan. Ayush will talk about X-rays. Manish Kothari is going to talk about EMG nerve conduction study, SSEPs and MEPs. And Abhilash Dhruv is going to talk about CT PET scan in the spine. The third program is in April, on April 11th, lumbar canal stenosis. Stay tuned in. Remember, BSS Con 2024, we hope to be that all of you will participate in big numbers, and we will have a grand time over there. I would finally like to thank our sponsors, Aquila, Intas, and their products, Gabapin, Gabapin NT, Gabapin ME. Thank you very much. And thanks to all the audience. If there are any questions, let's take them for the next 2 to 3 minutes before we close shop. Any questions from the audience? Amit?
Sir, any experience with the conus medullaris syndromes?
Any this thing experience with conus medullaris syndromes, Devesh? Devesh is the senior most among us, probably has the most experience.
No, I have not. No experience.
Yeah. I haven't seen any myself. Conus and medullaris syndromes we might have seen in tubercle spines where there is affection at D12L1, but I have never seen a D12L1 disc per se. Anybody else has any experience whatsoever who can answer this question?
Sir, I think the most differentiation is for a trauma case to differentiate between the terminal conus medullaris syndrome and the cauda equina syndrome. There is one more entity called as an epiconus syndrome, which is slightly higher than the conus level. Conus and cauda equina more or less are interchangeably used. Epiconus, there may be some mild upper motor neuron signs in the lower limbs followed, and also mixed lower motor neuron. But I think prognostically they behave the same, and to differentiate them clinically in a disc prolapse case is something which is, I think, clinically not going to come in the scenario.
Right. Aman has asked, what are the chances of recurrent disc prolapse after discectomy? Generally, it depends on the literature you read. Generally, between 2 to 12% is what is quoted in literature, though there are some studies which have higher recurrence rates also reported. So patients with foot drop of 6 months, does it recover after root decompression? Agni, you are online. Please tell us. Does it recover after 6 months of complete foot drop, power grade 0?
So it's very, very less likely that this will recover. A painless foot drop is something which you, a neurological recovery in a painless foot drop is something you can never ever promise to a patient. And again, the decision in this scenario, it's between you and how much patient are willing to understand the same. But as a neurological recovery, we cannot promise anything in such a scenario.
Right. Devesh, dural tears during doing a discectomy, do you repair them always? What is your plan?
If possible, if it's a small rent or it's a longitudinal tear, I would always like to repair it.
Okay.
But it's a ragged tear, then if it's not possible, then I try my best with Duragen or something to cover it, with T-seal to cover it, tight closure, and a drain in the subacute region. But if possible, always try to repair it.
Right. Satyen, an interesting question. I think a theoretical scenario. L5S1 extraforaminal disc and L4-5 lateral recess stenosis. How do you proceed?
You mean both together?
Yeah, I've never seen that.
If it comes, I guess we'll decompress both.
Yeah, decompress both. At L5S1, you probably end up doing a facetectomy, so you would have to fuse also.
Maybe.
So
Exam question.
in this scenario, if patient doesn't have a deficit, a root block would be a salvage option because a L5 root block will address both the issues.
It's very theoretical, the question.
Yeah. No, but it happens actually. It happens sometimes. You see, in a stenosis patients, it's a possibility. It can happen. But luckily for me, I have had this situation once. I could get away with a root block.
Right. So Silva asks, when should you do a laminectomy instead of just a fenestration? When there is a huge central disc, you could consider that. If there is a significant stenosis, you would consider it, right? If there are migrated discs which you cannot see very well, you might want to consider that. Conjoint nerve roots are another example. So lots of indications. There is no. So you must remember that your surgery has to be adequate. There is this huge fear in the minds of people that, oh, laminectomy, how can you do for a discectomy? That's a wrong fear. You should do whatever is necessary to decompress the nerve root in a safe and adequate manner, right? Okay, any other questions from any of the people who are online here with us?
There is a question about the case which you had showed that in the case 1, was the cyst with T12 element disc addressed?
No, it was not. I did exactly what was told by Devesh and by the rest of the panel, that we just tackled. I did an L4 laminectomy. I did a excision of the lower half of L3. I removed the sequestered disc from L4 in front of the L4 body. I checked the intervertebral disc space at L4-5. I looked for the L3-4. There was no frank prolapse over there. So I just left it without actually incising the disc and tried to remove any fragment. Agni, there is a question how to diagnose this fragment in relation to the nerve root, whether it is in the axilla or the shoulder. On MRI, is it possible?
So yes, it is possible. So if you have a root disc fragment which is inferiorly migrated and you can see it between pedicle and your nerve root, then you know it's a shoulder disc. If it's inferiorly and medially migrated, then expect it to find in axilla. If patient has a list, then that clinical scenario can also help you to understand if it's an axillary or a shoulder disc.
Right. I think with this, we will call this meeting to an end. I would like to thank everybody and hope to see you again on 7th of March for the next webinar. And to all BSS members, fellows, and residents, we look forward to seeing you on Friday, the 21st of February for our clinical meeting. Thank you and good night.